A French trial that was published a few years ago established that upfront chemoradiation is actually inferior to starting with chemotherapy. For a while, the standard practice has been to start these patients on gemcitabine and follow, maybe look to see if they have responded or not responded, maybe look for resectability, but then the response rate to gemcitabine is so poor that very few of these patients ever got to have surgery. The LAPAC trial that was presented looked at the combination of gemcitabine and nab-paclitaxel. In the initial trial, in the IMPACT trial, the gemcitabine nab-paclitaxel was only used in metastatic population, so we didn't have any data for basically efficacy of this treatment in the locally advanced population. So the LAPAC trial established that 36% of the patients responded to treatment, and about 15% of them actually went for surgery. There is also the, a meta-analysis of a few smaller FOLFIRINOX studies that are done in the locally advanced population, and about 28% of those patients actually were able to go for surgery. So I think those numbers are impressive, and I think that what that tells us is that as our chemotherapies are getting better when we treat locally advanced patients, we should not forget that we should reevaluate them for resectability. It is not a done deal, and so for medical oncologists, we should not forget that, you know, when we give these patients stronger, more potent therapies, we are potentially rendering them resectable, and every single time they have a staging study, we should discuss it with our surgeons to see if they're at a point for resection. They may not be, but you know, those few that we can find and resect them are worth the effort.